Thank you, Chuck. I'm Sam Metz. I'm a member of Oregon Physicians for National Health Program. Two of my colleagues, at least, are on the call, Bruce Thompson and Mike Huntington. I was one of 14 gubernatorial appointees in Oregon to work on a universal healthcare task force. We worked for 2.5 years. We had an outside consultant who did the numbers for us. I am going to race through what we did, give you some personal impressions of what I learned about single payer and the public, and then allow questions. Our task force filed its report in September. That is on your chat. And if you don't have it, I also sent my email. Basically, we based our report on the actuaries who said if we used the closest we could come to a single payer format in Oregon, our state would provide a greater breadth of benefits to a greater number of people, spend $1 billion a year less without compromising overall provider payment. This, in fact, confirmed a previous study in Oregon in 2017 performed by the RAND Corporation. We recommended to the legislature in our report that the legislature take the next step and create a board, universal healthcare board, that would do the actual dirty, disgusting work of trying to create a benefit program and a payment schedule before we even tackled how are we going to create a new tax program that would convert what people currently pay in premiums, out-of-pocket payments, and self-funded plans divert that into a single payer board. The politics in Oregon are such that the creation of this board was very much hearkened to the Affordable Care Act. That is, every Democrat in the legislature voted for it, every Republican voted against it, except for one Republican who voted for it and then left the Republican Party. You can be sure, I'm going into my personal impressions here, that when a healthcare bill passes the legislature and it fractures along party lines exactly, no one's read the bill and nobody cares what it does. It's a party vote. My take-home message is when we talk about single payer, we should focus it on healthcare financing. Single payer, now we're getting personal here. Single payer does one thing only, but it does it better than anything else. It provides better care to more people for less money without compromising provider payment. No other known format does that. It achieves this miracle by taking what we're already spending on healthcare and diverting a significant portion of money from insurance and billing and administration into actual healthcare. That's, in Mike's terms, that's our elevator speech. But there's more to it than that. Based on all of the questions that we on the task force and our legislature gets about, give us details about this single payer plan, we need to state all of the problems in healthcare that single payer does not cure. Everyone we speak to wants to know, will it do this? Will it do that? What about me? What about them? What will it do? And the answer is usually no, we won't fix that. Here's what our single payer proposal in Oregon will not fix. It will not fix the inadequate workforce. It will not fix the fact that Oregon can't generate enough medical professionals to meet the workforce needs, either for primary care physicians or nursing. Single payer by itself does not directly address the high cost of prescription medications. There is nothing intrinsic in our single payer plan that will reduce the rapid increase in healthcare costs that are going higher than than inflation. It will not address the geographic healthcare deserts in our massive states, We have some congressional districts that are larger than the state of Connecticut, and they don't have hospitals. It will not address diversity in the workforce. It will not directly affect medical fraud by providers or patients. It will not directly affect the complex credentialing system that every healthcare system keeps to itself. It will not address wasteful, unneeded, expensive medical procedures. And it will not address daily lifestyle habits that generate downstream expensive healthcare costs. All single payer will do is provide better care to more people for less money. And if that's not good enough for you, then you don't have to listen any further. However, single payer does provide us with tools that we can use if we choose to do so that can address all of these other problems that by itself single payer doesn't touch. For example, if Oregon uses its single payer system to create a single statewide drug formulary and a single statewide drug purchase plan, we can reduce the cost of prescription drugs. If we can create a single electronic medical record accessible by all providers, we can reduce, not eliminate, we can reduce duplication of tests that don't need to be done. We have the tool with the single payer system to have what might be called congestion pricing for provider payment. That is, we'll pay providers more to work out in Harney County, which is a ranching area that doesn't have a physician in it, than in my neighborhood, which is infested with physicians. We can use that tool. If our single payer system can have a single statewide fraud office that reviews every medical bill for appropriateness and fraud. As a matter of fact, the Vermont plan, which as you remember was never implemented, was estimated by the FBI to reduce healthcare spending by close to 5% in the state just by detecting and deterring fraud. We can use our single payer system to have a single statewide credentialing service. So if you're good enough to work in one hospital, you're good enough to work in any hospital. And finally, a statewide single payer system can apply quality metrics to all healthcare systems and come up, we can detect inefficient healthcare delivery around the state and implement statewide corrections. But our single payer system is only better care to more people for less money. It does that better than any other plan. We should sell this as a better healthcare system, not an ideal healthcare system. Single payer is a next step, it's not a final step. Thank you for listening to that tirade. This is what I learned last summer, and I would be very interested in hearing any responses from you folk who have had similar experiences in your own states. Chuck, I am going to let you handle the chat and the questions in case people don't raise their hands.
Okay, and people can do it manually as well, just with your own hand up. We can do it that way. You can use the chat, you can use the reactions button. And if you do have a question or comment, please keep it brief because we have a lot to get through today. And note that in the chat, there are a number of resources that folks have attached regarding Sam's contact information, the Oregon plan, and Paul dropped a link in there for one-click politics. So questions or very brief comments?
I'll tell you what, I see Michael Pan has his hand up, and then there's a question from Robbie Stern, and I'll get to that second. Michael, you're on the air.
Yes, thank you so much, Dr. Simon Metz, for that presentation. Very informative. So my question is, when drafting the single-payer bill at the state level, I'm just very curious. So what I heard is that although it passed at the state legislature, but it never made it to the governor's desk. And I'm just very curious for the veto at the governor's desk. Was it because a lot of surgeons and specialists did not support the bill due to the fact that they might lose more money and other entities?
I want to be sure, Michael, that I'm in the right state. As you may remember, in Vermont, the legislature enacted the single payer plan, but did not create a funding plan, left that to the governor because the legislature didn't want to take responsibility for doubling the state budget. The governor did not want to do that either, so he created a commission to make a recommendation about doubling the state budget. When the Vermont Commission came back and said, you're going to have to collect twice as much money as you do now, the governor said, we can't double the state budget, and he axed the plan. In Oregon, we have not proposed a benefit schedule and a payment rate, nor have we proposed a tax plan that would replace private funding. So this has not yet gone to the governor for approval. Our obligation was to turn a report back to the legislature. However, the legislature was not obligated to act on our report, nor are they obligated even to read it. This is why the ball is now in the court of activists around the state to make sure their state legislators read this report and that they demand that their state legislator respond to it. I think that's the, I hope that answers your question.
Thank you, Mike. Let's go to Robbie.
Yes, Robbie asked a question about the, what would be the effect on jobs of switching to a single payer system? That's a question that always bubbles up. Our task force did not respond to it. Fortunately, about 20 other state single payer plans over the last 20 years have. Very few of them have looked at jobs lost in the insurance industry, and fewer still have looked at jobs created by the new demand for healthcare. In those studies that look at both of them, perhaps the best one was from California Nurses Association sponsored IHSP report about 10 years ago. The number of new jobs created in healthcare because of the new demand for healthcare would be 2 to 3 times as large as the number of jobs lost in billing. So if we make this transition, there will be, for example, in Oregon, maybe about 12,000 people who make their living exclusively from healthcare insurance or healthcare billing. They're going to be out of a job. However, we recommended that there be transition costs so they can be retrained. They will also be in a job market in which the number of new openings is 2 to 3 times as large as the number of people looking for jobs. And while they look, they and their family will get health care. That's about as soft a landing as you can engineer when you're doing a massive shift like that.
Is that good, Robbie?
Um, I, I think that one of the questions that we're trying to um, um, struggle with in talking to Representative Jayapal about her bill is getting the financial support to people that would lose their jobs while they're transitioning to the new jobs. And that's why I wanted to ask Samuel if they had addressed that, because it's going to take more than healthcare coverage to get them through that period. But thank you. Your answer was great, Samuel. Thank you.
Great. Peter, it's been a long time since we've spoken. Good to see you alive and well. I hope you're still publishing.
Likewise, sir. Yeah, I wanted to raise a question since you were talking about financing. How much the question of capturing federal dollars for programs like Medicare and Medicaid and so forth that are coming into Oregon, how did that figure in the calculations? And what are the, I don't know quite how to put this, what assumptions can you make or not make about that money coming in, and how do you respond if it doesn't become available? If it's not possible to capture that funds under the waiver provisions of the Affordable Care Act?
The short answer to that is federal collaboration is critical, and we cannot create a more efficient healthcare system without at least federal waivers, and ideally a super waiver bill created like the Ro-Khanna bill that actually was designed by Jim McDermott of Washington. If we cannot pool federal funding, then we end up with a multi-payer system. The savings in administration from the single payer system is the possibility that I, as a provider, can run an office without a cashier. Somebody comes into my office for help, I can say, I will take care of you. I will build a single payer system. They will figure out where to get the money. However, if I need to complete to stay the way things are, before I can take care of you, I want you to fill out these 3 pages of insurance forms so I can determine whether you're Medicare, whether you're Medicaid, whether you're Indian Health Service, whether you're S-CHIP, whether you have a private policy, whether you have an employer-sponsored policy, whether you have an exchange policy. That throws the sand back into the gears, and much of the efficiency of a single payer system is lost. So to repeat the answer, for a single payer system to work, that is to reduce administrative costs and turn that into healthcare, federal collaboration is critical.
Thanks, Sam, and thanks for the questions. Real quickly, I will forward to the group here the Pennsylvania bill, actually, that does address the previous question from Robbie about jobs and also giving people a golden parachute for 2 years, $60,000, up to $60,000 per year. So there is a more intentional focus on just transition over there. As far as the waivers are concerned, one of the questions I'm going to be talking to Sam about this week is we don't really have an on-the-ground representation in Washington, D.C. I've talked to David Loud about this, a lot of other folks. I think we need to figure out a way to have a clear representation from the single payer community working at the state level to make sure that we get Congress and, if necessary, the executive branch to provide those necessary waivers. So that's a political question, but it's an important one that I just want to put in a parking lot. We'll talk about later. Bill, we'll go with you for the last question, and then we need to pivot to some other business. Bill?
Thanks, Sam. Thanks for your presentation. Wondering, long-term care is one of the ways we impoverish people paying for healthcare. Has Oregon been looking at including or not including long-term care coverage in their state-based plan?
Yes, our task force spent a lot of time on long-term care for the very reason that you mentioned. It can really tear a family apart. We could find no examples in the United States or anywhere else in the world in which long-term care and medical care were folded into the same system.
Mm,
There are examples of single-payer healthcare around the world and even in the US. All self-funded plans are essentially private single-payer systems. Many nations and a few employers, and of course many individuals, can enter their own realm of long-term care insurance, but combining them together, we would be the first in the world to do that, and we did not want to experiment. We only wanted to do things where we knew it would work because there were just too many working models. Thank you for the question.
Thanks, Bill. And there's some more stuff in the chat. I don't want to just ignore it entirely, but we'll have to circle back to that just for purposes of getting through other critical items today. Sam, thank you so much for coming in. Very eloquent, very thoughtful, honest, straightforward, no beating around the bush here. We have to figure out a lot of different questions. And again, one of them is, how do we get those waivers, as well as the ERISA waiver? So that's really important. These are important steps we have to figure out. So Mike, since we have Robbie with us, I would love, oh, I'm sorry, Dave Garibaldi, you have your hand up. Was that for Sam or somebody else? What, you're good? Okay, I just saw your hand go up. Robbie, can you give us a thumbnail, just review of what folks need to be doing as far as ACO REACH? This is a very well-educated crowd here. Folks know what's going on, but maybe just kind of give an update on kind of some of the strategy developments that we're working on together.
Well, Chuck, part of what we learned in the almost year-long campaign that we ran to try and terminate ACO REACH is that this is a crowd that knows this. The problem with what's happening with Medicare, it's being privatized like crazy, and ACO REACH is one element of the privatization. I think that we have to continue the call for the termination of ACO REACH, and it needs to come from many other places in the country, because it is clear that CMS wants to get every single Medicare beneficiary and traditional Medicare and an accountable care organization by 2030. They've said as much. So we need to do that, but we need to work on educating people around the country about the danger that Medicare faces as a result of the combination of Medicare Advantage and the privatization of traditional Medicare. We are going to lose Medicare unless we stop the fleecing of the Medicare Trust Fund and the takeover by the large insurers and the Wall Street businesses of Medicare. So we are involved in building a campaign, working with people from around the country, and I'm so excited to see this group here because I know it's something that you all share concern about. If we could lose Medicare, and the opportunity for a public Medicare for all if they continue on the road they're on, and we have to stop it and we have to drive it back, and that's what we're trying to do. So we have to contact our representatives and senators and say, you need to terminate ACO REACH and the privatization of traditional Medicare, and we need to stop the profit takers from absolutely fleecing the Medicare Trust Fund. Chuck, does that cover what you wanted me to cover? You're muted, Chuck. It's a heck of a thing if I'm telling you you're muted.
I know. So, it goes off here, it gets kind of noisy. But related to that too is the AHIP Medicare Advantage endorsement letter that's circulating in Congress. Do you want to add a couple words about that? And if Mike, if you have or others have any links to drop in the box as far as petitions, talking points, one-click politics is our avenue for activism. And then I'll bring up David Loud. I think he has something to say when you're done, Robbie.
Oh, sure. Well, David, you want to address the AHIP letter thing, or you want me to? unmute, buddy.
Go ahead, Robbie.
Okay, so what's happening is that every year, as I'm sure you all know, AHIP circulates a letter through Congress asking them to sign on in support of what a wonderful program Medicare Advantage is. Initiated by Social Security Works in DC, there is an effort to pull, they had over 400 members of Congress sign on to that letter in 2022. We are making an effort and we are reaching out to people around the country to communicate to their members of Congress that they should not be signing on to the letter this year. There is abundant information at this point, including the breathtaking article that was in the New York Times, I think it was on October 9th, that talked about the 5 largest insurers defrauding the Medicare system by upcoding and delaying care and denying care, somewhere around $12 billion in just 2020. So we think that it's time to put pressure on our congressional delegation to sign no letter that is now being circulated. It's being circulated in Congress right now, talking about what a great deal and how wonderful Medicare Advantage is. I'm had a conversation through text with Alex, God, I haven't seen your, Alex, who's
Lawson?
Executive Lawson, this morning, and he is meeting with the head of the new Democrat caucus in the House today to talk to them about making sure that their people do not sign on to that AHIP letter that's being circulated now. Our organization, Social Security Works Washington, Healthcare is a Human Right Washington, Puget Sound Advocates for Retirement Action, and PNHP Washington have all sent letters to the entire congressional delegation from Washington saying, do not sign on to the AHIP letter as they're circulating it right now. And we're asking our individual executive board members and others to communicate to them not to sign on to the AHIP letter. The goal is to pull at least 100 people off of that letter that they, from the signatures that they had last year. David, go ahead and add to it.
Yes, I put into the chat a sample letter that folks in Washington State, different organizations, as Robbie said, have been sending to our congressional delegation. And I encourage you to save that letter and take a look at it, because it includes a lot of the documentation that is available on the flaws and excesses and dangers of Medicare Advantage, from the Inspector General of HHS, from the New York Times and other sources. So that letter, I hope, will be useful to you in coming up with your own messages to your own congressional delegations. And that letter, if Robbie said this, I'm sorry to repeat, that letter, the AHIP letter, the American Health Insurance Plans letter, started circulating in the Congress this week. And we expect that it will be toward the end of the month that that AHIP wants to finalize getting the signatures on that letter and to publicize it. So time is of the essence right now on this particular issue and this particular campaign on Medicare Advantage. So please do something with it. Thank you.
Thanks for that, Robbie and David. Great work that you're doing. I did mention here in the box, because we are looking for more partners around the country on both of these campaigns, but ACO Reach more specifically, we have our next strategy group meeting is on the 25th, next Wednesday at 8 a.m. Pacific, 11 a.m. Eastern. That's in the chat, just to call your attention to that. And yeah, and any questions about ACO Reach or the AHIP letter? Is everybody pretty clear about that? And Mike, you want to bring up something, and Robbie, and then David again.
Yeah,
Mike?
I showed this briefly, showing it again. This is a one-click politics campaign, which we can talk about more later. that you can use the similar format, same program for any legislation that you're concerned about in your state, at the state level, county level, and federal level. This one happens to be focused on this AHIP cartel letter. So once you fill in your information here, wherever you send this, anywhere in the United States, and then click next, it brings up that person's 2 senators and representative. In this case, that's all we targeted. And you just submit it, and it tells them, we respectively urge you not to sign the annual AHIP letter, and so on. So anyway, that link is in the chat, and you can copy it.
Okay, quickly, Robbie, David,
Yeah.
Betty.
Real quick, could you email me the link for the meeting next Wednesday? Because I have an organization that's interested in sending someone to it. That's the first thing. And the second thing is, if you're sending it as an organization from a state, you should really think about sending it not only to the 2 US senators, but your entire congressional delegation. And you can do that by sending it to the chief of staffs of the various members of the House of Representatives in your state, which is what we did. We sent it to the chiefs of staffs, and then individuals can send it to their own representative.
And Mike and I will follow up. We'll set up a Zoom meeting then Wednesday. Thank you, Dave. And then Sam. Let's get. We're at about 15 minutes. Go ahead.
Okay, so I also wanted to mention that Robbie and my organization, Puget Sound Advocates for Retirement Action, is, as he said, trying to build a national campaign on these things, on the privatization. And in our newsletter, the Retiree Advocate, we're going to have a key article every month. It's a monthly newsletter. I'm going to put into the chat the link to the newsletter that we published in January outlining the campaign in the year ahead. And that's the one thing. So I'll do that in the chat. The second thing is, Robbie, could you say a word about Ed Weisbart's webinar on March 20th? Because that's something that everybody here will be interested in.
Yeah, so we're having Ed Weisbart come to a webinar that we're going to be publicizing nationally. Ed is on the board of PNHP and just a wonderful presenter, very, very good, very clear. He's going to be talking about the threat of the privatization of Medicare and what we need to do about it, how we got to this point and what we need to do. I have a flyer. I think I sent it to you, Mike. And if you wanted to share with the folks here, that flyer I sent that had that wonderful graphic on it, please feel free to do it. It's a great flyer. And if you don't have it, I'll resend it.
Let's see, Sam, I think Betty, you took your hand down. Sam?
Thank you.
Your hand.
Looks like Barbara Pearson asked about privatization of Medicaid. A brief answer: in Oregon, Medicaid is administered primarily by regional coordinated care organizations, CCOs. There are about 16 of them in Oregon. One of them was purchased by an out-of-state for-profit organization. This is about the worst example you can get of privatization of Medicaid. It really has rankled both its creator, former Governor John Kitzhaber, and the legislature that Oregon taxpayers are paying money for health care and a percentage of it is being siphoned off for out-of-state investors. It's a very real problem.
So, but thank you. I really appreciate the answer. I'm just wondering, it's not as huge a plum for private equity, though, is it, as Medicare and REACH? I wanted to make that statement and I didn't know whether it was true. So I know that 90% of Medicaid is in managed care. organizations, despite the fact that they're bad. I mean, they're worse performance. But I just wondered if there were, I don't have the impression that private equity is lining up the way they are for the REACH programs to try and get them. And I just wondered if I was being provincial or whether that they are. And yours is the first one that I hear about, a specific one for Medicaid. But I wondered if others know of anything, and you can just tell me in the chat, it'll be fine. I don't, but I was trying to make that statement, and then I said, is it true? So I don't think it's quite the plum that Medicare Advantage is.
Right. I think it's
Thank you.
Yeah, I believe it's $1.6 trillion in Medicare, correct? That's on the table, Robbie?
Say it again. I'm sorry, Mike.
Yeah,
Oh,
by
Chuck, say it
2020,
again.
by 2028, yes.
$1.6 trillion. That's what's in
That's
play.
right. Yeah.
That's, I don't know about the Medicaid side of it. If anybody wants to address that more. I mean, Sam already did.